Very good afternoon to all. So I'll be presenting the results of 27 gauge MIVS assisted scleral fixation of intraocular lens and AIOS2025 guided study. So we know a number of suture as well as sutureless techniques for SFIOL have been described, and amongst these sutureless methods have gained popularity as they bypass the risk related to sutures. Techniques such as Yamane's technique have gained prominence, however challenges related to the procedural complexity and steep learning curve it remains. So alternatively, a number of modified Yamane technique have been described. So we have also tried to do a 27 gauge MIVS assisted scleral fixation of intraocular lenses and try to look at the outcomes using AS-OCT. So the study assessed the post-operative intraocular lens tilt, the decentration and iris to IOL distance, and their impact on the visual and refractive outcomes. So it was a retrospective study, and the relevant preoperative, intraoperative, and postoperative details were collected. The preoperative data included the patient age, the gender, the BCVA, the intraocular pressure, the specular endothelial cell count, and a comprehensive anterior and posterior segment evaluation. Postoperatively, all these patients underwent an ASOCT using Anterion. The exclusion criteria included was the secondary glaucomas, the corneal opacity or the scarring, previous retinal pathology, or optic atrophy or neuropathy. So how did we calculate the IOL matrix? The IOL tilt was defined as the angle between the corneal topographic axis and the central axis of the IOL. The IOL decentration was defined as the distance between the fixation point on the corneal topographic axis and the central axis of the IOL in the cornea. And the distance of the IOL from the posterior iris was defined as the perpendicular distance between the posterior surface of the iris and the IOL at the pupillary margin. So post-operative data was collected and any post-operative complications observed during the follow-up period were also recorded. A pars plana vitrectomy was done only in cases that were associated with posterior lens or IOL dislocation or an associated vitreous hemorrhage. An anterior vitrectomy and a thorough port site vitrectomy was done in all the cases. Intraoperative surgical videos were reviewed to assess any complications encountered during the surgery. Necessary statistical analysis was done. So just a short video to show the technique. So after securing the infusion, 227 gauge trocar cannulas was inserted roughly at a distance of 1.5 millimeters in a biplanar pattern along the horizontal meridian, just above and below. So once this was done, then the IOL was inserted, and then using 27 gauge max grip forceps, that was inserted through the cannula. Then the haptic was held with the trocar, with the forceps, and the cannula was then shifted onto the trocar. Once the haptic was extruded, then using the heat cautery, the haptic was flanged. A similar procedure was done on the either side. And once we felt that the required amount of haptic has been flanged, then the haptics were tucked inside the scleral tunnel to achieve the perfectly aligned IOL. And the infusion cannula was removed. So it was basically more like a sutureless, flapless, glueless technique for scleral fixation of the IOLs. So now coming on to the results, a total of 39 patients were included with a mean age of about 34 years. Male to female ratio was 29:7. Most of the indications were the dislocated or the dropped IOLs, phacodonosis or subluxations, posterior lens dislocations, or previous surgical aphakias. The pre-op mean BCVA was 0.85, pre-op mean intraocular pressure was 16.6, and the mean endothelial cell count was 2400. At 3 months of follow-up, the mean BCVA improved significantly from the baseline. IOP and endothelial cell count was more or less similar with no statistical significant value. So now coming on to the important aspect of the study, that what were the AS-OCT measurements. So the IOL tilt in degrees was roughly 3.58. The IOL decentration in millimeters was 0.22, and the posterior iris surface and the distance of the IOL from the posterior iris surface was about 0.76 millimeters. So now if you go and review the literature, about 5 degrees of IOL tilt and about 0.2 to 0.3 millimeter of decentration is clinically tolerable to the patients. And when coming on to the post-operative complications, so about 4 patients, they had an IOL tilt immediately during the post-operative period and they required a repeat surgical intervention. 3 patients had vitreous hemorrhage which resolved within a period of 1 month. And 2 patients had choroidal detachment which again resolved within 2 weeks with the use of oral steroids. Now the mean refractive spherical equivalent was roughly 1.14. That is that all of our patients had a mean hyperopic shift. And when we tried to correlate with the IOL matrix, we found that there was a positive correlation between the distance of the IOL from the posterior iris surface, though there was no correlation between the IOL tilt and the IOL decentration. So these are the graphs showing the correlation between the mean refractive spherical equivalent and the IOL matrix. So just to conclude that the 27 gauge MIVS assisted scleral fixation of intraocular lenses, they demonstrate a favorable outcomes in terms of IOL tilt and decentration, contributing to improved visual acuity and reduced post-operative complications. And utilizing AS-OCT for post-operative assessment provides precise measurements of IOL positioning, aiding in the refinement of surgical techniques. So this is just a review of literature. We try to compare our study with other studies which have actually looked at the IOL metrics using AIOST or UBM. So the IOL tilt was more or less comparable of what is existing in the literature, but IOL decentration was significantly lesser using a smaller gauge vitrectomy, smaller gauge sclerotomies. Thank you.
Next.
Thank you.